Welcome to our sonography lecture on renal pathology, part 6 of 14, renal diseases for the sonographer. This lecture will cover acute glomerulonephritis, acute interstitial nephritis, lupus nephritis, AIDS, sickle cell, hypertensive nephropathy, papillary necrosis, and renal atrophy. This chapter actually presents some more difficult information. And I say that it's a little bit more difficult because we are not so much diagnosing based off of what we are seeing, rather than that we know something is wrong with the patient and we are just seeing the effect that that disease has on the kidneys. So we're not going to go into most of these images saying, oh, we just diagnosed AIDS on this patient, or we just diagnosed lupus on a patient. What we're going to see is the effect of that systemic disease onto the kidneys. There are also a couple other diseases that we'll talk about that just affect the kidneys, and we still need to know how they look. Again, those are going to be more diagnosed by what are the patient's symptoms, what have they been going through, what do their labs say, and what does the ultrasound say. So the trickier part about renal diseases is that they overlap in a lot of ways. And what I want you to focus on then, because of that, is I want you to focus on the name of the disease, kind of what it's doing to the body or to the kidney, and then what it looks like on ultrasound. Because there is so much information in this chapter, we could literally just do lectures on each of these diseases and it could be hours long. I don't want to get into that much detail. So what I've provided you here is a nice chart that you can use to kind of have a quick reference visual to the diseases that we're talking about. You can see how echogenic kidneys applies to AGN, AIN, lupus, and AIDS, where decreased echogenicity goes along with sickle cell. So you can have this quick reference guide to see where there are similarities and see where there are differences in planning your studying and learning for this section. Starting with acute glomerulonephritis, commonly abbreviated to AGN, it is the necrosis or the proliferation of the glomeruli in the kidney. If you recall back to the microscopic anatomy of the kidney, we learned that the glomeruli is home to the area that is going to let some of the blood cells in, and then they let them back out, and it sucks out some of the substrate, which is then going to be moving through the tubules and getting added back to the blood, or some more is removed. So the glomeruli is really kind of that first section that takes the blood cells in through the afferent arterial and then lets them back out through the efferent arterial, kind of doing that first round of filtration. When the glomeruli die, that's kind of the first part of where filtration happens. So when that glomeruli start to die, that leads to poor functioning kidneys. So we're going to see abnormal lab values for these patients. And because the body can't filter out the extra water or the extra waste or toxins that were in the body, it can't control blood pressure. Then we start to see that the patients have edema, hypertension, and anemia. On ultrasound then, acute glomerulonephritis presents as enlarged kidneys, and they're typically echogenic. So here's an example of our acute glomerulonephritis kidney. Our next diffuse renal disease is acute interstitial nephritis. Now, acute interstitial nephritis occurs when the interstitium, which is the area that kind of sits around the tubules that is going to participate in some of the exchange of toxins and waste and water and salts and all of that, that's going to become inflamed. And that usually becomes inflamed due to some sort of systemic infection like scarlet fever or diphtheria. Another reason that the interstitium can become inflamed is also due to an allergic reaction. And we often abbreviate acute interstitial nephritis down to AIN. So now when the interstitium isn't working well, that means that it's going to either take out too much stuff or it's going to let too much stuff keep going through the urine. So what we see in these patients is uremia, which is excessive nitrogen in the urine, proteinuria, which is too much protein in the urine, hematuria, blood in the urine, and then rash, fevers, and eosinophilia. The rash and the fever eosinophilia go along with the fact that there is an infection in the body. Now, on ultrasound, the kidneys again are going to be enlarged. They're going to appear echogenic when the disease is active, and they can take on kind of a mottled appearance. So here's an example of acute interstitial nephritis. So you can kind of see that these are much brighter compared to the liver or to the spleen. If we're on the left side, we can kind of see that it's a heterogeneous appearance to the kidney, but very bright. Lupus nephritis is a systemic condition. It's an autoimmune disorder that causes the body to kind of attack itself. And lupus very commonly affects the kidneys. Up to 50% of the patients diagnosed with lupus will have lupus nephritis. And so when the lupus attacks the kidneys, it makes them not work very well. It causes renal insufficiency, and it'll cause blood in the urine, protein in the urine. Patients, again, can't control their high blood pressure or can't control blood pressure because the kidneys aren't working well. That results in hypertension. Another big thing that we see with lupus nephritis is renal vein thrombosis. So on ultrasound, we're going to see that the lupus nephritis kidneys are small, they're echogenic, and we'll commonly see renal vein thrombosis in there as well. So here is an example of a lupus nephritis kidney, which is small, echogenic, and if we were to look at the renal vein, there's a good chance that we will not see any blood flow in there due to thrombosis. Our next systemic disease is AIDS. AIDS, or acquired immunodeficiency syndrome, is a highly contagious disease that destroys T cells and then makes them replicate the AIDS virus rapidly, and then it starts to affect many organs within the body. The way that AIDS affects the kidneys typically results in dysfunction of the kidneys, and that's usually because of some other things that are going on, such as acute tubular necrosis, or ATN, nephrocalcinosis, which is deposits of calcium in the pyramids, AIN, which we already talked about, acute interstitial nephritis, and glomerulosclerosis. So the AIDS virus attacks the T cells, attacks other organs in the body, and kidneys being one of them is really just going to render the kidneys dysfunctional. Now, on ultrasound, the kidneys in an AIDS patient are going to appear probably mostly normal to slightly enlarged in size, and they're going to be echogenic. So here's an example of a patient with AIDS that has very echogenic kidneys, and again, they're going to be kind of normal to maybe a little bit larger. So you can see how the last four diseases that we've talked about all make the kidneys bright. So that's one thing that kind of keeps them similar. But the thing that makes them separate or different from one another, lupus includes small kidneys, where the other three were big kidneys. Lupus has thrombosis, where the others do not mention that. So if you can kind of pick out things that make them similar, so you can group them in one way, but pull out the thing that makes them different. So when you're looking at patient history questions, when you're looking at those kind of complicated scenario questions, you can pull out the key information that you need to clue in to what disease we are looking at. Moving on, we're going to talk about sickle cell nephropathy. Sickle cell is a disease that we'll talk a little bit more about in the spleen lectures, but sickle cell is a blood disorder, and it causes the red blood cells in the body to be crescent moon shaped. Typically they're called biconcave discs, so they're circular and kind of dented on either side. The sickle cell shape to the blood cells actually makes them really difficult for organs to filter them because they're used to that circular disc shape of normal red blood cells. So when you have these kind of crescent moon shaped cells trying to get through the glomerulus, they can't get through very well. They get stuck in there. It just makes it really difficult for the kidney to do its job. So when the kidney can't filter the blood very well, again, we're going to see acute glomerulonephritis. We might see some renal vein thrombosis along with this. Papillary necrosis, which means the papilla are dying because they're not getting enough oxygen, because they're not getting blood, because the red blood cells can't maneuver through the small vessels. And then we might also see some hematuria in these patients as well. On ultrasound, If there's acute renal vein thrombosis, the kidneys are actually going to look very enlarged. If you think about how the blood comes in through the artery, the renal artery, goes through the kidney, well, if it can't get out because there's thrombosis, all that blood is just going to kind of keep pumping in there, and the kidney is going to become kind of over engorged and large with all that extra blood. What also happens then is that it's going to decrease in echogenicity, and then we're going to see the kidney kind of take on some extra fluid, so it's going to look edematous as well. So that is when there is an acute renal vein thrombosis actively engaged. Now, in subacute cases, if the patient doesn't have renal vein thrombosis or is currently not suffering from any acute diseases associated with their sickle cell, the kidneys do take on still that large appearance, but they're a little bit brighter. So in the setting of acute vein thrombosis, they're hypoechoic. In just normal, I've got sickle cell but no thrombosis, the kidneys look a little bit brighter. So here's an example of just kind of, I always say that these kind of look fluffy, but that fluffy appearance, the technical term is edematous. So they kind of have this kind of engorged, hypoechoic, kind of puffy look to them. Our next disease then is hypertensive nephropathy. So hypertensive nephropathy, hypertensive refers to the blood pressure, so it's increased blood pressure. Nephropathy refers to renal pathology. So hypertensive nephropathy is renal pathology that occurs because of uncontrolled high blood pressure. And when there's high blood pressure in the system, the kidneys are responsible for trying to control that, taking out the right amount of salts, producing the right hormones to affect how the blood pressure is working in the body. So if the kidney can't do that, then the blood pressure kind of gets out of control. And when the blood pressure gets out of control, it damages the kidney. So it's kind of the cyclic thing. The kidney can't stop blood pressure, and the blood pressure is damaging the kidneys, and it just makes the problem worse. So it ends up being kind of a progressive renal damage because they bounce off of one another, getting worse as the other one can't get better. What we see then in hypertensive nephropathy on ultrasound then are very small kidneys. The blood is not getting in there very well. The kidney can't really do much with it once it is in there. And so the kidney starts to render itself kind of useless at this point. So we start to see them become small. We might also see some scarring of the kidney. Those will just kind of show up as a little bit brighter bands running through the kidney. So it kind of gives it kind of this fibrous look to it. And oftentimes this is bilateral because it is systemic. It affects both kidneys. So here is an example of a unilateral hypertensive nephropathy. What we're seeing here is the left kidney measuring 8.8 centimeters. We can see that it is a little bit smaller. The renal cortex is quite a bit thinner. We've got a large replacement of fat within the sinus. So this is very typical of hypertensive nephropathy. This goes right along with renal atrophy as well. On this one here, we can see that this one is relatively spared. It's nice and long. It's got a nice thick cortex, normal appearing sinus. So this one is undergone more damage due to that hypertensive nephropathy. Our next disease is papillary necrosis. We have mentioned this before in that the papilla can die, and when they die, we start to see issues in the way that patients' kidneys end up functioning. So that papilla, if you recall again back to our microscopic renal anatomy, the papilla are at the very apex of the pyramids. So remember, the collecting tubules come in, collecting all the urine from the nephrons. The collecting tubules then enter into the pyramids, and they end at the papilla, right at that very pointy part of the pyramids. The papilla then go and connect to the minor calyces. And so this area is very sensitive to not getting enough oxygen. And if it doesn't get enough oxygen, it starts to die, and it starts to kind of slough off and cause problems for the patient. It's no longer doing its job. So the papillary cells at the apex of the renal pyramids start to die, and this can be due to quite a few things. It can be due to pain medication, specifically like ibuprofen. Excessive ibuprofen can cause issues. Sickle cell disease, remember, they're very sensitive to how much oxygen they're getting, and so if the sickle cell disease is causing low oxygen levels in the kidneys, then this area is going to start to die. Patients with diabetes are more likely to have kidney issues, obstruction issues. Pyelonephritis is an infection of the kidney, and then even renal transplants, again, following ischemia to the kidney, causes this papillary necrosis. With the papillary cells dying off then, it is not uncommon for this area to kind of get scarred and infected. So we see stones, infections, and an increased likelihood of cancer as well. When a patient has papillary necrosis on ultrasound, what we will see is fluid right at the area that the pyramids and the cortex join one another. So we see fluid at the corticomedullary junction. And these spaces of fluid are either round or they take on a little bit more of a triangular shape. So here's an example of papillary necrosis. We can see right where the junction of the cortex and the medullary are, we are seeing these round fluid-filled structures. Renal atrophy then is our last renal disease that we need to talk about. Renal atrophy occurs when the kidneys become smaller, and this is usually as a result of many disease processes that affect the body. We'll also see that renal sinus lipomatosis, or the increase of fat within the renal sinus, occurs during this transformation. The problem with renal atrophy is that the kidney is no longer functioning very well, and so we'll start to see that in their labs that the kidney is not functioning. On ultrasound then we will see small kidneys. We see a very echogenic and large sinus, and then we'll see thin cortical tissue, usually less than 1 centimeter. So here's an example of renal atrophy. We have the right kidney here, and we have the left kidney here. Both these kidneys are very small. You can see how much space the sinus takes up, how echogenic it is, being replaced by fat. And then you can also see how thin the cortex is as well. So this looks very similar to hypertensive nephropathy. It's kind of the same process in the fact that the kidney is no longer functioning very well. It's become smaller. The difference is that this can happen for multiple systemic diseases. Hypertensive nephropathy is strictly from uncontrolled blood pressure. Here's another example of renal atrophy. Again, we just have a very tiny kidney. Usually it's going to be bilateral because it's being affected by systemic diseases. We have a very thin cortex with increased fat. There's actually just a little bit of fluid in this kidney as well. And yet another example of renal atrophy. Again, we can see a thinning cortex, and then we can see that sinus lipomatosis, where we have an excessive amount of fat within the sinus, making it very echogenic and much wider or more expansive than what we would expect in a normal kidney. And that is the end of renal diseases. So again, focus on what the disease name is, how it affects the kidney, and what it looks like by ultrasound. Up next, we're going to talk about renal failure.